Good evening or good morning if you are in a different time zone. I'm Nadim Kafarani, European Clinical and Business Manager for Ultrasound. I'm very pleased to welcome you in this new MSK Ultrasound webinar organized by Canon Medical Systems. This webinar will introduce how ultra-high resolution ultrasound can be used to acknowledge complex ultrasound and visualize fine structures associated. For that, I feel really honored to introduce our speaker for today, Professor Carlo Martinoli from Genoa in Italy. I'm sure it's not necessary to present him, but for people coming from another planet, let me do it. He is assistant professor and associate professor of radiology at the University of Genoa. He has published over 200 scientific articles in international medical journals and has held over 1,000 invited lectures and international courses or congresses. He is current chairman of the Educational Committee of the SSR and member of the Educational Committee Board of the ESR for musculoskeletal radiology. And today, he will show you ultra-high resolution ultrasound of the wrist and the hand and how to deal with a complexity game on APOI prismatization. Professor Martinoli, I give you the word and the probe. Thank you.
So thank you very much, Nadim, for your kind introduction. And welcome, everybody. Of course, I have to say good morning, good afternoon, good evening, and good night, everybody. Today the task is very complex because due to the complexity, due to the anatomical complexity of the hand, my choice was to select a speech dealing with the volar aspect of the wrist and hand. Of course, there is no time to address the dorsal aspect, the fingers at the same time. So the choice was to examine and discuss with you all the structures located on the volar aspect of the wrist and hand. And so we start now. And just to make a focus on the distal forearm, where we can identify some important muscles, and they are the flexor digitorum superficialis, the flexor digitorum profundus, as you can see here in this cadaveric slice. Then there are other structures around. You can recognize here the median nerve, the flexor pollicis longus. This tendon located superficially is the flexor carpi radialis, and this is the flexor carpi ulnaris. But more centrally, you can also see the palmaris longus. But interestingly, when you check the flexor digitorum superficialis and the flexor digitorum profundus, you see some differences. The profundus is characterized by four tendons for the index, the middle, the ring, and the little fingers, and they are arranged in a line superficially relative to the muscle belly. So the position of this tendon is a bit eccentric. The structure of the flexor digitorum superficialis is different because you see not the same orderly arrangement of the intramuscular tendons. You can see some structures here with a different orientation. And the important point to remember is that there is a different order of the areas of the flexor digitorum superficialis for the individual fingers. And so the area of the muscle for the index finger is not that is not located in the most radial part of the flexor digitorum superficialis, but it lies on the other side of the muscle tissue for the middle finger, as you can see here. And then the arrangement for the ring and the little finger is as expected. So there is an inversion in the position of the two of the index and the middle fingers in the most radial part of the flexor digitorum superficialis, but not in the flexor digitorum profundus. Here is the median nerve, the other muscles I described it before. And this is what happens when we ask the patient to flex and extend the middle finger. So you see the most radial part of the flexor digitorum superficialis moving, And now the patient is moving the index, and you see that in the flexor digitorum superficialis, there is a activation of a muscle area that doesn't correspond to the area of the flexor digitorum profundus. So there is an inversion in the position, the respective position of these areas. It's very interesting. This is an example of a patient with a closed injury of the flexor digitorum superficialis and the flexor digitorum profundus tendon at the level of the palm. You see some concavity in the skin here, and this was the ultrasound image showing the interruption in the tendon continuity at this level. So you can see the long axis of the flexor digitorum superficialis and profundus here, and they are interrupted at this level. So asking the patient to flex the finger, no way to flex the index due to the interruption of the two tendons. And placing the probe in a more proximal position at the level of the distal forearm, this is what it's possible, what we saw. So a selective atrophy of the area of the flexor digitorum superficialis supplying the index. And this was not observed at the level of the flexor digitorum profundus. Note that there is no muscle change. The muscle change was affecting just the flexor digitorum superficialis. And this may explain the structure of this muscle that is very special, very peculiar. The different areas of this muscle to the fingers works autonomously, they are in individual muscle bellies embedded in one big muscle, like a jellyfish, in which we have the tentacles, and the tentacles represent individual entities in the jellyfish, the same thing. So it's very interesting to understand this difference of the flexor digitorum superficialis relative to the other muscles. In the same area, we can also recognize some anatomical variants. One specific variant observed at the level of the wrist and possibly producing a lump on the ventral aspect, as you can see in this example, is related to anomalies in the palmaris longus. So you know that the palmaris longus is a vestigial muscle, and it served to expose the claws in some mammals. Of course, this is not an action that is useful in humans, but the muscle remained as a rudimentary structure. So you know that the palmaris normally has a proximal muscle and then a very slender tendon crossing the length of the forearm and then going to insert distally at the level of the fascia in the hand. But in some instances, the muscle may be located distally and the tendon proximally. So in these cases, when we place the probe at this level, just on the ulnar side of the flexor carpi radialis, we can recognize the tendon, but not any muscle structure. And going down, we can identify the additional muscle located superficial to the flexor digitorum superficialis. So, and this transverse view of the distal forearm, we are able to demonstrate different muscles, too many, because you can identify the pronator quadratus, the flexor digitorum profundus, the flexor pollicis longus, flexor digitorum superficialis as well. What is that? Is the reversed palmaris. The point is that when we have this muscle, the bulk of the muscle may compress the median nerve. So this kind of anomaly may be predisposing to median nerve compression at the level of the wrist. Note these two images. They are related to a case who was submitted to ultrasound examination for a carpal tunnel syndrome. And the image on the left side is obtained at rest, and you see the anomalous muscle and the median nerve looking underneath the muscle. And in the image on the right-hand side, you can see the muscle during contraction, and you realize that the muscle presses the median nerve. You see the undersurface of this muscle is now concave, and so you can imagine that the muscle here can create some direct compression, can squeeze the median nerve against the flexor tendons. This is not commonly observed, is a variant, is an anatomical variant, but it may be relevant from the clinical point of view. Other variants, one that is relatively interesting is the Lindbergh-Comstock deformity. So it is related to a connection between the tendon of the flexor pollicis longus and the corresponding tendon of the flexor digitorum profundus of the index finger. So the two tendons coming from two different muscles are joined by a common tendinous connection, and the result is that when the patient flexes the thumb, as you can see here, it flexes autonomously at the same time, automatically, the index finger, as you can see in this case. So symptoms may develop in this patient when you flex the thumb and you try to extend the index, of course, or vice versa. And this is, in general, this kind of condition is not really important. It may become important in cases of people who works in a context in which some independent functionality of the fingers is required, such as a musician, for instance. It is believed that the Lindbergh-Comstock deformity may represent a persistent vestigial structure as well, because you know that in primates, non-human primates, the flexors are represented by one structure only for all fingers. So, and in this case, the connection between two different muscles characterized by different function may represent a vestigial residual. This is an example in which we see the coordinated movement of the two structures, the flexor pollicis longus and the flexor digitorum profundus for the index finger, moving together at the same time. And in the other video clip, you can also see the conjunction, the bridge between the two tendons, and you see the conjoint movement of the two structures. So remember, this is a variant related to a very tiny tendinous bridge connecting the two structures. And it has to be recognized when the patient is submitted to ultrasound examination, because he or she realized that the movement of the thumb is not completely autonomous. Then another interesting structure is the palmaris profundus, that is also named musculus concomitans nervi mediani. This means a muscle running alongside the median nerve or within the median nerve, a muscle accompanying the median nerve at the level of the distal forearm. So this kind of muscle is not really palmaris. It doesn't derive from the palmaris, but it arises from the flexor digitorum superficialis. And in the video clip you see here, when you check the median nerve, you are able to demonstrate the fascicles, and this one is not a fascicle, but is a tendon. And the tendon accompanies the median nerve, and finally, it will go to insert into the deep surface of the distal retinaculum or the palmar aponeurosis. So this is the image of this additional structure as it appears on an MRI. You see the flexors, you see the position of the median nerve, and the accessory tendon located in a more superficial position. Again, like the palmaris, the reversed palmaris, the palmaris profundus may be cause of carpal tunnel disease. And this is because during flexion of the finger, the tendon becomes tense, and so it may press the median nerve, as you can see in the video clip and on the lower part of the slide here. You see during flexion, the tendon presses the median nerve, and you can see some kind of deformity of the median nerve, which appear which assumes a saddle shape, as you saw before. So moving to the carpal tunnel, the carpal tunnel houses 9 tendons, and they are the 4 slips of the flexor digitorum superficialis. So the 4 other slips from the flexor digitorum profundus and the flexor digitorum superficialis and profundus have the same territory of distribution. So they supply the 2nd, 3rd, 4th, and 5th fingers. And then we have the flexor pollicis longus. And the thumb is characterized by 2 phalanges only, and so it requires one long flexor, and the flexor pollicis longus is typically located on the radial side of the carpal tunnel. So the other tendon you see radially and in a closer position with the trapezium is the flexor carpi radialis. So this is an image of the carpal tunnel, and in this image you recognize the usual structures represented by the retinaculum. This is the flexor retinaculum. This is the pisiform on one side of the image, the tubercle of the scaphoid on the other side. This is the position of the flexor pollicis of the flexor carpi radialis, and then within the tunnel you can see the different tendons coming from the flexor digitorum superficialis and profundus, and of course the median nerve in a superficial position, just radial to the midline. So in the median nerve here is depicted in its short axis. You can see the fascicles, you can see the outer epinevrium looking hyperechogenic. But these are the structure you have to check, of course, but there is much more. So what the content of the carpal tunnel includes not just this structure, but other relevant structures. And if you give a look to the deepest part of the tunnel, you realize that the structures here are thickened. These are not tendon, but this deep band located just superficial to the floor, to the bony floor of the tunnel, is represented by some important ligaments. So within the tunnel, we have 2 tenosynovial spaces named bursae, and these tenosynovial spaces envelope the tendon in a different way. One is devoted to the flexor pollicis longus and is named the radial bursa, or the radial tenosynovial envelope. And the other one is the ulnar-sided bursa, and it envelopes the 8 tendons from the flexor digitorum superficialis and flexor digitorum profundus. So the appearance, the shape of this tenosynovial envelope is illustrated in this image. So we have 2 different spaces, and this can be seen when we examine patients in which the sheaths are distended by some effusion. In this case, we realize that within the carpal tunnel, we also have to consider the mesotendons You see a big mesotendons here connected to the sleeve for the index finger from the flexor digitorum profundus. And there are also other mesotendons located in between the flexors. And in this image, in this microradiographic image, you can see the mesotendons located within the tunnel. So when you place the probe correctly at the level of the carpal tunnel, you see the tendons very reflective, very echogenic, and they create a uniform pattern. Basically, but as soon as you tilt the probe, you realize that that tendons becomes dark as a result of anisotropy, and you see more. You see some structure enfolding in between them, and they are related to the supporting stromal tissues. So remember that there is a potential space between the two tenosynovial envelopes, between the radial and the ulnar bursa. And this space can be crossed by the median nerve, especially when you perform scanning using a position that we can call the pulcinella position, very Italian position. And we ask the patient to flex the hand and to join the fingers together. You can see the median nerve passing from a superficial position down and enfolding in between the tendons of the index and the tendons of the flexor pollicis longus. And this is because there is a passage here for the median nerve. The median nerve may migrate deeply in the tunnel during this kind of position. If we consider the envelopes of the flexor tendons at the level of the carpal tunnel, this is the radial sided one, the radial bursa investing the flexor pollicis longus. Then the other tendons are invested by the ulnar bursa, and the ulnar bursa ends here just in the proximal in the palm. Then in general, the tendon of the index, middle, and ring fingers are naked in the mid palm here, and they are invested again by a sheath distally, just before the level of the A1 pulley. Tendons may be reinvested by a tenosynovial sheath, and the tenosynovial sheath continues until the end. So, which is the reason for that? Remember, the lumbrical muscle arises from the flexor digitorum profundus tendons. So, this is the reason for which the flexor tendons are not invested by a tenosynovial envelope at this level. Then the little fingers has a different arrangement of the sheath. In many cases, its sheath at the level of the digit communicates with the proximal ulnar bursa. There is a continuity at this level. Of course, there are many variants. These variants are illustrated here in the slide, but in approximately 83% of cases, the sheath of the little finger communicates with the ulnar bursa, and so there may be some diffusion, for instance, of infectious processes. There is due to the continuity of the sheath from distal to proximal. So it's a unique tenosynovial space. This is a long axis image at the level of the flexor digitorum superficialis and flexor digitorum profundus, and asking the patient to flex the fingers during some exerting some resistance by the examiner. You can see that at the point where there is the beginning of the lumbrical muscles, you can see some difficult gliding of the tendon of the flexor digitorum profundus. And this is because the muscle is attached to this tendon. The other tendon, no, because the tendon of the flexor digitorum superficialis is free. So the lumbricals. No, the lumbrical muscles are four, and but they are different in terms of shape and complexity. Remember that they are attached to the flexor digitorum profundus, but in the first two lumbricals are unipennate in structure. What does lumbrical mean? Lumbrical means earthworms, no? And this is due to the shape of these muscles. They are very tiny, very slender, and they typically arise here from the tendons and insert on the radial side of the extensor hood. So they are located ventrally in the palm, so they should act as flexors, but the tendon migrates dorsally to reinforce the extensor hood. Remember this point. So when you look at this schematic drawing, you realize the unipennate structure of the first and second lumbrical. Here you see the position of the flexor tendons. This is the flexor digitorum superficialis and the flexor digitorum profundus, and you see the lumbrical muscle attaches to the side of the flexor digitorum profundus. But going more ulnarly, you can have a different appearance of these lumbrical muscles. They are connecting, as you can see here, the flexor digitorum profundus tendons of two adjacent fingers, of the third and the fourth fingers, and you see the common origin in this area. So more distally, the flexor, lumbrical muscles pass on the ventral aspect of the deep transverse metacarpal ligament, and they change their direction. They use the deep transverse metacarpal ligament as a pulley to redirect their course dorsally. Remember this point. So how to identify the lumbrical muscles is not difficult, because they are located in between the tendons, and they are the most ventral muscle we are able to demonstrate. So this is an image obtained at the level of the metacarpophalangeal joint. You see the palmar plates here. You see the flexor tendons of two adjacent fingers, and you see the deep transverse metacarpal ligament here forming a floor for the lumbrical muscle. Here is an image of the lumbrical muscle, of the distal part of the lumbrical muscle. You see the tendon of the lumbrical, and you also see the common digital neurovascular pedicle with one artery, some veins, and a small nerve. So this is another nice anatomical view in which you can see the position of the dorsal interosseous, and this is the lumbrical emerging from the ventral aspect of the hand and then moving dorsally to reinforce the extensor hood. And this is a dissection in which you see the relationship of the lumbrical muscle, very slender at this point, with the hood. So you see that the tendinous fibers open distally, and this is the ultrasound appearance of the lumbrical. You see the tendinous fiber gliding during extension and flexion of the fingers. So remember, lumbrical muscles are very tiny muscles, and but they are very important because their primary function is to create something like a fine-tuning between the flexor and extensor musculature. So they are a very tiny structure, but they coordinate, they orchestrate precision movement, and they regulate the strength of flexors and the extensors. No, it's interesting to compare some animals, like apes, and humans, and in terms of evolutionary paths. Remember that lumbricals are very big in primates, but in humans are very small. At the same time, in humans, there is an increased number of proprioceptors within the muscle, and this is just to reinforce the role as a tiny, very the regulation role of this muscle related to the movement of the finger. And this is particularly true. The density of proprioceptors is higher in the first two lumbricals, the ones supplied by the median nerve. The other ones are supplied by the ulnar nerve. And this is probably due to higher requests in terms of precision pinch movements. So remember this point. I would like to show now something about the wrist structures, and we started the examination using a 24 probe. We place the probe at the level of the wrist, and we see the structure contained at the level of the carpal tunnel. We have to recognize the landmarks. So this is the tubercle of the scaphoid with the flexor carpi radialis on the top. This is the pisiform, and here we see the retinaculum. We see the ulnar nerve here. There is an accessory muscle, the abductor digiti minimi. Here, this is the ulnar artery, and in the middle we see the median nerve. We realize that the median nerve is not just made of fascicles, but is characterized by an outer epinephrium, a hyperechogenic ring. So, and this is very evident in these images. So if I tilt the probe and if I make the tendinous structure black, I can see some hyperechogenic structures remaining within the carpal tunnel, and they are related to the mesotendons. And then I see the deep ligaments forming, reinforcing the floor of the tunnel. So remember, tendons ends here in the tunnel. They don't reach the bony floor of the tunnel, but because there are some ligaments. So you know the ventral ligaments visible here. They include the radiolunate, the radioscapholunate ligament visible here as a fibrillar structure. Then you can also have, if you tilt the probe a bit, the radioscaphoid capitate ligament. Here it looks a bit more hypoechoic as a result of anisotropy, and in between this ligament that is located at the level of is more distal, and the proximal band of the radiolunate ligament, we have a weak space here, not in which the capsule is not reinforced. Then we also have the other ligaments on the ulnar side of the tunnel. You can see the ulnar triquetrum, the ulnar lunate ligament, and the same. If I tilt the probe, I can see the ulnar capitate ligament that is located very close to the ulnar border. So this is ulnar, and this is the area of the ulnar triquetrum capitate ligament. So we have different structures here. Remember the ventral aspect of the scapholunate ligament. No, the scapholunate ligament is usually examined with a dorsal approach. No, dorsally, this ligament is so nicely depicted. But if we select a ventral approach, we can perform the same kind of movement with the ulnar and radial deviation to check the status of the ligament here. So lumbricals. So when we enter the tunnel and we place the probe at the level of the distal part of it, so we see the flat appearance of the trapezium on one side. This is the hook of the M8. Now I make the tendons hyperechogenic, but then going more distally, we can see that the lumbricals emerging here, and then the most proximal part of the lumbricals may enter in some instances within the tunnel. Note the close relationship of the lumbrical with the flexor digitorum profundus. The flexor digitorum superficialis, you see, is completely free. Now I change probe. I move to the 22, the OK stick, and I place the probe at the level of the mid palm, just to give to have a better depiction of the lumbrical structures. You see the flexors. This is the unipennate lumbrical, and then you know, this is a different structure. This is a bipennate. This is another bipennate structure. So is the lumbrical tendon visible? The answer is yes. This is, we are scanning over the second metacarpal, and the structure you see here is the dorsal interosseous. The dorsal interosseous is very big relative to the lumbrical. This is the lumbrical. This is the dorsal interosseous, and this is the radial collateral nerve of the index. So if we follow the interosseous, this is the tendon. The tendon may look very echogenic. It's easy to demonstrate here. For the lumbrical, the tendon is very tiny, no? And we have to follow the muscle until the end. We can follow the tendon using transverse planes, but we can also decide to select another technique to image the tendon of the lumbrical. We have to place the lumbrical in its full axis, and at the end, try to extend, please, against resistance. You can see the very slender tendon visible here. This is the tendon of the lumbrical, the one indicated by the arrow. So the lumbrical are very slender but long structures, and this is the technique to image them. Okay, now we move to the radial side of the ventral wrist and to discuss another very important tendon. The tendon of the flexor carpi radialis is a big tendon, and as you know, this tendon enters the wrist, passing over the tubercle of the scaphoid. Then it passes on the ulnar side of the trapezium, just underneath the tubercle of the trapezium, and finally it changes its direction. It becomes deeper and is oriented towards more ulnarly to insert at the level of the base of the second metacarpal. So this is the the course of the flexor carpi radialis, the close relationship with the trapezium, you see here, with the scaphoid, with the trapezoid, and this is the relationship between the flexor carpi radialis and the flexor pollicis longus. The flexor pollicis longus is contained within the tunnel. The flexor carpi radialis is firmly stabilized against the trapezium by dense connective tissue, and it runs outside the tunnel, as you can see in this cadaveric view. So when we examine the flexor carpi radialis, and we are proximal with the probe, everything is really easy because the tendon is parallel to the skin, is fibrillar, is a big tendon, and you see the tendon reaching the tubercle of the scaphoid, and then going down. The tendon disappears in this area. It looks very anisotropic, and it's important to change the position of the probe and to reorient the probe in this way, and you can see the tendon going to insert at the level of the base of the metacarpal. This is a very important point to remember, and the tendon has to be evaluated distally because it may be impinged distally by osteophytes, or in cases of triscaphe joint arthritis, and the osteophytes may create a degenerative tendinopathy, some ganglion cyst in the area, and or some effusion distending the sheath of the tendon at a more proximal level, because the tendon is firmly stabilized there. There is no space for sheath distension at the level of the wrist, but the distension may occur proximally. So this is an example of a thickened and degenerated tendon. You can also see the ventral osteophytes coming from the triscaphe joint. And in general, you have two different pictures. In one case, you may have just a sheath distension by effusion. The tendon looks normal. So this, in these cases, when you have a triscaphe joint arthritis, there may be some passage of joint fluid outside within the sheath of the flexor carpi radialis tendon, and the joint fluid may then distend the sheath of the tendon with a normal tendon. On the other side, the tendon may appear very swollen, degenerated, with some fissuration, with some peritendinous changes, as you can see in the lower image. When you compare the image of the median nerve here with the image of the flexor carpi radialis, you can see the bigger size of the tendon relative to the nerve, and this is obviously not normal. So you see the irregularities in the trapezium, in the scaphoid here, and these are typical signs associated with the tendinopathy of the flexor carpi radialis, or with the tendon sheath distension. Close to the area of insertion of the flexor carpi radialis, we have the another clinically important area in the hands, the area of the trapeziometacarpal, trapezio-trapezoid, scaphotrapezium, and trapezium, and second metacarpal joint. So in this case, the most relevant joints to explain the trapeziometacarpal arthritis are the trapeziometacarpal joint and the scaphotrapezium, because they are arranged in the axis of longitudinally compression of the thumb. Remember that the condition of the trapeziometacarpal arthritis is so common in postmenopausal women, and there is a very high incidence of this condition, with the incidence reaches 25% in cases of isolated involvement of a trapeziometacarpal joint. There may be coexisting involvement of the triscaphe and the trapeziometacarpal in 8% of cases. But remember that when we have this kind of conjoint involvement of the two joints, the patient tends to become more symptomatic. The condition is much more painful. Of course, the diagnosis is very easy. It's clinical. If you wish, you place the probe. You can see the osteophytes on the ventral aspect of the joint, but the examination may be also more complex. And this is because we have to consider not just the presence of osteophytes in this area, but also the status of some important ligaments. And they are the anterior oblique and the dorsal-radial ligaments located in these respective areas. This is a cross-section of the trapezium. This is the dorsal aspect. This is the ulnar aspect, and you see the relationship of the anterior oblique ligament with the flexor carpi radialis, and the relationship of the dorsal radial ligament with the abductor pollicis longus. So the joint is basically a saddle-shaped joint, inherently unstable, and the anterior oblique that is located here is very important from the biomechanical point of view, as it may stabilize the joint, stopping volar metacarpal subluxation. The dorsal-radial ligament is a bit less important because it prevents dorsal metacarpal subluxation, but both ligaments are relevant stabilizers of the trapeziometacarpal joint. If we refer to the anterior oblique ligament, remember that is made of two components, one superficial, that is dissected in this image, and one deep or big-shaped components, very important. The ligament is approximately one millimeter thick and is 10 millimeter long, and it can be identified on the ulnar side of the trapezium in close proximity to the position of the tendon of the flexor pollicis longus and the tendon of the flexor carpi radialis. This is an image of the dorsal radial ligament, and you see the relationship of this ligament with the abductor pollicis longus in a more dorsal position. When you examine the trapeziometacarpal joint, remember the grinding test, produced by subluxing the metacarpal ventrally with the examination thumb, and in cases of joint instability, you can see some joint-wide changes. In this case, we see the osteophytes, but there is no much instability of the joint. And in this other case, you can see a widening of the joint space with no endpoint. So now, how to image the flexor carpi radialis and the anterior oblique and dorsal medial ligament? So we place the probe at the level of the wrist first, and the tendon of the flexor carpi radialis is a very good landmark to identify the ligament. So we start here. This image is well known by everybody. You see the flexor carpi radialis here passing in close proximity with the retinaculum, then stabilized by a specific retinaculum over the top of the tubercle of the scaphoid, and then going more distally, you see the tendon as it becomes deeper, and it's located now on the other side of the trapezium. This is the trapezium. The trapezium is flat, and you see the tendon going down to insert at the level of the base of the second metacarpal. So if I place the probe longitudinally, this is the image, and we see the scaphoid. This is the waist of the scaphoid. This is the tubercle. This is the proximal part of the scaphoid and the radius. This is the tendon of the flexor carpi radialis curving over the tubercle of the scaphoid. This is the trapezium and the tubercle of the trapezium. After that, I have to change the orientation of the probe And now I see the tendon going more distally to insert at the level of the base of the second metacarpal. So remember, don't stop your scanning here when you see the tendon so nicely, but too proximally until the end of the scaphoid. But go distally in the at the level of the wrist, because here is the critical point for this tendon, because the tendon may be impinged by osteophytes coming from the ventral aspect of the triscaphe joint, and some synovitis in cases of rheumatological disorders may also cause tendinous problems. So this is the long axis image of the tendon. Then I move the probe towards radial, the tendon disappears, and I see the articular surface of the trapezius covered with some cartilage. And this is the position of the anterior oblique ligament. So this is the anterior oblique ligament. If I rotate the probe, I can see the ligament here depicted in its long axis. So this is the trapezium, this is the metacarpal, the first metacarpal, and this is the location of the ligament. After that, I place the probe at the level of the trapezium metacarpal joint. I perform some stress, the grind test now, and I check the second structure, so now visible dorsally. So I try to place the arrow over this structure, and so this is the other ligament, the dorsal one, and this ligament is located in close proximity with the tendon. So this is the position of the ligament, and you see the ligament here, and the structure visible more radially. I use more gel to have a better image. Is the tendon of the abductor pollicis longus. So the abductor pollicis longus is here, and this is the dorsomedial ligament. So after that, the intrinsic muscles of the hand, and we give now some very simple rules to identify them and to distinguish them from each other. So when we go and scan the muscle structures located at the level of the tenar eminence, remember to start anytime at the level of the flexor retinaculum, at the level of the carpal tunnel. The probe is placed transversely here. And remember that the first muscle to appear is the abductor pollicis brevis. The abductor pollicis brevis is very superficial. It arises from the flexor retinaculum and the scaphoid tubercle, and then it extends externally down to reach the first phalanx, the proximal phalanx of the thumb and the capsule of the first carpometacarpal metacarpal phalangeal joint. So this is the muscle arising from the retinaculum. Is a very superficial structure. Deep to it, we can identify a second muscle, the opponens pollicis, and this muscle arises from the same structures, from the flexor retinaculum and the tubercle of the trapezium, and it will go to insert at the level of the metacarpal bone of the thumb, and it reaches the radial side. It curves and reaches the radial side of the metacarpal, of the first metacarpal. After depicting these two muscles, we change the orientation of the probe, and we place the probe obliquely in the short axis of the flexor pollicis longus tendon. And this is the flexor pollicis longus tendon in the center of the image. And in this image, we can recognize the abductor pollicis brevis, the opponens located here, and then close to the tendon, we see the two bellies of the flexor pollicis brevis. Remember that the flexor pollicis brevis inserted into the radial side of the base of the proximal phalanx, and this is the muscle located on both superficially and deeply to the flexor pollicis longus. And to have a better depiction of this muscle, in my opinion, is good to place the probe in the short axis of the flexor pollicis longus tendon. And the deep to the flexor pollicis brevis, to the deep belly of the flexor pollicis brevis, we can see the adductor pollicis. The abductor pollicis, remember, is made of a complex muscle. It includes a transverse and an oblique heads, and they both arise from the third metacarpal, and they will insert on the base of the proximal phalanx of the thumb. You see here the abductor arising from the third metacarpal. So these are the relevant structures on the at the level of the thenar eminence. Now I try to demonstrate them by placing the probe at the level of the carpal tunnel again. I defreeze. I have to recognize the landmarks. So this is the scaphoid on one side. Here, this is the piezoform. And then I see the retinaculum nicely visible here. And then when I check the soft tissues located superficial to the retinaculum, I see this is a superficial muscle. This is the abductor pollicis brevis. Is the most superficial structure. After that, I go more distally, and I see a second muscle. It is usually thicker than the first, and this is the opponent's pollicis. So abductor pollicis brevis, opponent pollicis. After that, remember to place the probe in the short axis of the flexor pollicis longus. And when I follow the flexor pollicis longus in this area, I can see the superficial belly here. This is the superficial belly of the flexor pollicis brevis. This is the deep belly of the flexor pollicis brevis. The tendon looks hyperechogenic now as a result of anisotropy. And this is the adductor pollicis. So I have to orient the probe obliquely to be in the long axis of the adductor pollicis. It's very big muscle. Deep to it, we can see the dorsal interosseous of the first space. And then I see here the origin of the adductor pollicis from the third metacarpal. So this is the technique to scan the thenar eminence muscles. So this image is the ulnar side of the palmar aspect of the hand, and in this image we see the arrangement of the two superficial muscles of the hypothenar eminence, the flexor digiti minimi brevis and the abductor digiti minimi that is located in a more external position. So these two muscles arise from the flexor retinaculum. And in this image, you also see the close relationship of this structure with the two sensory branches of the ulnar nerve. They are devoted to the skin supply of the fourth and the fifth finger. So when we scan this area, remember to place the probe transversely at the level of the fifth metacarpal, and that's the image. You can see the arrangement of the flexor digiti minimi brevis here in a more radial position. Then the most ulnar structure is the abductor digiti minimi, and the opponent is located deeply in close apposition to the shaft of the fifth metacarpal. So superficially, in this image, you see the nerve branches of the ulnar nerve. So what is that? This is a butterfly. Why is a butterfly? So it's in the importance of the muscles located at the level of the hypotenar eminence is related to the compression of the ulnar nerve at the elbow level, no, in cases of cubital tunnel syndrome, no. And one of the things to do when we examine this kind of patients is to check the status of the ulnar innervated muscles in the hand, and they include the interossei and the muscles located at the level of the thenar eminence. So, which is the best technique to understand if there is any loss in bulk or mild sign of atrophy affecting these muscles as a result of denervation? You should invite the patient to place the two hands on the table facing together and the probe in the middle. So this is the resultant image. You see the image of the butterfly. This is the body, and these are the two wings, no? And the two wings represent the intrinsic muscles of the hypotenar eminence on the right and left hand. So in cases in which we have atrophy of this muscle, the butterfly will lose one of its wings, as you can see in this example. So it's a very simple technique, but very accurate to compare the trophism, the volume of the thenar eminence muscles. So very simple. The important point is to align the position of the two hypotenar eminences close with each other, as I can show there. And now I can give a scan over these muscles. I defreeze the image. Again, I see the carpal tunnel on the ulnar side. The bone here is characterized by a curved appearance. This is the pisiform. And on the radial side of the pisiform, we see the Guyon tunnel. And the Guyon tunnel is made, it contains the ulnar nerve visible here and the artery. This is the ulnar artery. So in this particular case, as we described it before, there is an accessory muscle located superficially here, is the accessory abductor of the digiti minimi. So the fascicles of the ulnar nerve here splits, and they form one or two superficial bundles, the sensory bundles visible here. So these are the two bundles. This is the for the fourth, and this is for the fifth finger. There is the superficial branch of the ulnar artery following the nerve here. This is very nicely depicted. And then when I'm here at the level of the Guyon tunnel, I have to go more distally, and I see the retinaculum inserting at the level of the base of the pisiform. You see the retinaculum fans out, and this is not just the retinaculum, but is also a ligament. No, this is the pisohamate ligament, and the pisohamate ligaments form the floor for the motor branch of the ulnar nerve. So these are the sensory branches. They remains very superficial, and this is the palmaris brevis muscle located in the subcutaneous tissue. And this is the motor branch. So the motor branch of the nerve here passes underneath the origin of the hypotenar muscle. So here is the motor branch rejoining the main trunk. Then I go more distally. I see the motor branch separating from the sensory branches. This is the band, is a tendinous bridge, a tendinous band at the origin of the hypotenar muscle. Then when I follow the motor branch more distally, I see the hook of the M8 here. The nerve passes in closer position to the hook, and then it passes, it becomes very deep here. So it pierces, in some instances, the opponent's digiti minimi, that is this muscle, or it passes over the opponents, as you can see here. So this is the technique of examination of the Guyon tunnel. Remember not to place the probe just here at the level of the pisiform when you have to check the ulnar nerve, but you have to go more distally. This is the passage for the motor branch between the proximal origin of the hypotenar muscles and the piso-M8 ligament we demonstrated before. So this is the piso-M8. It's very thick, as you can see in this image. After that, I go more distally and I check the arrangement of the muscle I described before at the level of the fifth metacarpal. So you see that there is an external muscle here, and this is the abductor digiti minimi. This is an internal muscle, and this is the flexor digiti minima, flexor brevis, of course. And then I see a deep muscle in this position, and this is the opponent's. This is the opponent's digiti minimi. So superficial to this structure, the fascicles of the superficial branches of the ulnar nerve in the hand. So I think there is probably no time to include other structures, but believe me, this is merely the tip of the iceberg. We decided to discuss today the ventral aspects of the wrist and hand, with focusing on the palm for the most, because it's not really a well-known area by sonologists. And so I hope that this lecture was productive for you in terms of new knowledge and was not boring. So thank you very much for your attention and for your attendance to this webinar.
Wow. Wow. So first of all, thank you, Thomas Marie, for this fantastic lecture.
Well, my pleasure.
Yeah, it was really, really amazing. We have some few questions. We have time. So, yeah, do you normally look about radial and ulnar bursa in your routine exam, and do you frequently see some pathologies?
So if you mean the ulnar and the radial bursa at the level of the carpal tunnel, so yes, of course, I have to check the envelopes of the flexor tendons routinely. And when I check this kind of bursa, I don't know if the term bursa is the most appropriate. Is a term used by anatomists, but not by clinicians. So basically, the more than bursa, we should use the terms synovial, tenosynovial envelope. And when we scan the carpal tunnel, and we need to check if there is a thickening in the walls of these tenosynovial envelopes, indicating some proliferating synovium, and we have to start to check the status of the tenosynovial envelope of the flexors, placing the probe proximal to the carpal tunnel and distal to it, because the sheet tends to distend not just in the carpal tunnel where all the structures are compressed with each other. No, there is no space. No, everything has to be compacted, no, within the confined space of the tunnel. But remember, anytime you have to check this tendon and to rule out tenosynovitis, go proximal to the retinaculum and distal to the retinaculum, because you can see some tenosynovial effusion, not just in the carpal tunnel, but outside it.
Thank you. There are also some questions about standardization or steps for a dynamic study of the median nerve. Could you?
Yeah, if you wish, I can also scan. We have an equipment here, and so we can take the opportunity to scan directly, so I can show you the technique of examination. In general, I start proximally. I start here, and I identify the nerve at the level of the distal forearm in between the flexor digitorum superficialis, this muscle. I move the middle finger now, and I see the movement transmitted to the most radial part of this muscle. Then this muscle is the flexor pollicis longus, and now I can create some movements in the flexor pollicis longus. And finally, this is the flexor digitorum profundus. So I start proximally just to have an idea of the volume. I don't calculate the volume, to be honest. I just check the nerve in this area, and then I follow the nerve down. And I see the nerve crossing the space between the flexor digitorum superficialis and the flexor pollicis longus, and then the nerve passing across the space between the flexor digitorum and the flexor carpi radialis. After that, I continue to go down to place the probe in the short axis, and it's very important to identify a proximal level of examination. This is the proximal carpal tunnel, so the probe should include on the sides of the image this tubercle of the scaphoid on one side and the pisiform on the other side. I look at the nerve here, then I follow the nerve down. I have to tilt the probe to make the nerve more echogenic and to make the tendon more hypoechoic or more hyperechoic, depending on what I need to demonstrate. And I see the flat appearance of the trapezium on one side and the hook. So this is the distal carpal tunnel. After that, I go down and I continue my scanning of the median nerve until I see the nerve as it splits into the common digital branches. It's very important to start more proximal than the level of the retinaculum and to end your scanning in the mid-palm. And the reason is that the nerve is usually entrapped at the level of the proximal boundary of the retinaculum. But not uncommonly, we have a distal entrapment at the level as soon as the nerve exits the distal boundary of the tunnel. Let me check the nerve with the 22 megahertz probe. We start proximally at the level of the wrist, and you know that in the median nerve has a small branch here. This is the palmar cutaneous branch. You see the branch moving up, crossing the fascia. This is the antebrachial fascia, and then moving into the subcutaneous tissue. The nerve is now in the subcutaneous tissue, just ulnar to the flexor carpi radialis. And in this case, you see we have another branch here. So is we have two palmar cutaneous branches. You see the nerve, it looks like one fascicle, no? And the nerve, as it pierces the retinaculum, as it moves in a more distal position within the subcutaneous tissue. So these nerves are 0.2, 0.1 millimeter in size. There is another nerve to check, we have to go more distally, and this nerve is the motor branch of the radial. At this level, when we scan the most radial part of the median nerve, the motor branch should detach and migrate superficially to reach the muscles of the thenar eminence, no? And in this case, the nerve passes across this surface. This is the small nerve arising from the radial side of the median. So I perform this scanning plane routinely, starting proximally and ending at the level of the mid-palm. Of course, the diagnosis of carpal tunnel syndrome is clinical, but on ultrasound, if you perceive that the nerve becomes bigger and bigger at the level proximal to the level of compression, and then it changes its shape, it becomes more flattened. This is the visual sign that the median nerve is compressed, and the diagnosis can be done even if you don't measure the cross-sectional area of the nerve.
We can listen to you all night, I would say. So unfortunately, we have to stop. And I would like to say thank you again so much, David, for this fantastic lecture. Thank you.
Thank you very much. Goodbye.